Sorry. You can continue talking, just checking the sound. I did make it to the meeting on Friday in time, so thank you, with minutes to spare. I did walk for 2 minutes to the hotel. It was very nice at the shore. I did my thing, got in the car, and came back here. So, but thank you for those of you who recommended I spend some time at the beach. I touched no sand, so I didn't get a chance to go on the thing. And also, some of you, thank you for your help on Friday. And on Saturday for the open house. It was really very good. Thank you for the gang that helped out. A lot of interest in the program, right? Who was here? You were here? Who else was here? Yeah. Others? No? Well, thank you. Everybody's like shyly pointing. We actually had 2 sessions because there was overflow and the fire marshal, all that kind of stuff. So we wanted to. I just wanted to thank the students who helped out. That usually is very impressive, and they like the building because we had it at Bush Campus Center, and then we moved some people here, but we had to start some here because it was totally overflow. So I think that's good, and the tours went well. So again, thank you to you guys for all your help. All right, let's talk about heroin. We got up to. Did we talk about India, Pakistan, Iran? Okay. Did we talk about preparation from poppies? Okay, no. You guys are hilarious. I'm like, did we do this? Like I see heads. Did we do this? No. It's like, okay, very, very accentuated. Don't hurt yourself, though. Okay, well, the preparation from poppy is really very simple. The poppy, actually, the pods are cut, and sap oozes out, and that is raw opium. And that is scraped off, dried, and then it's refined to morphine, and then refined to heroin. So again, it's just an organic product. It's just a plant that is harvested. The plant is not harvested. The sap is harvested. And then there are various types of refining methods that we talked about. Okay, routes of administration. There seemed to be some keen interest the other day in routes of administration. Usual is parenteral. It works orally. It is administered subcutaneously, and the term is called skin popping. So if you want to, at your leisure, Google skin popping, but in the case you have the picture of what skin popping looks like. Some individuals, they'll just grab a piece of, a fold of skin, if they're a friend, and then they will, either somebody will administer it, or you simply administer it subcutaneously into some fat, like usually the forearms, behind the arm, in your thigh. Just administer it subcutaneously. Now the problem with that is that you will get subcutaneous abscesses. You will get infectious abscesses underneath. Okay, you'll see on the case that we have what that looks like. More and more people are smoking it because, again, if you smoke the heroin, it gets into the lungs and you get really rapid absorption, and you avoid the IV route. Folks don't like to do the IV because, number one, it may leave marks. Depending on what you do for a living, you may not want to have track marks. Obviously, you want to disguise it as best you can. So people will smoke it. People are also concerned about if they share needles, transmitting diseases, although now with needle exchange programs, that's less of a problem, but some folks might think of sharing needles, so to avoid that, individuals just smoke the heroin. It also gets into the brain very quickly, because again, anytime you smoke something, it goes right into the circulation, and it gets absorbed fairly quickly. We'll talk about that when we talk about crack cocaine. So smoking is a very, very interesting route. That's more popular. Also, snorting is a popular route. The bizarre routes of administration, we'll talk about those if you really unfortunately move down the route. People will inject it into their tongue because of the blood supply. Folks will inject it into the genitalia, which is a weird spot, painful. People will also administer it rectally. So those are all of the different ways. There are a couple of terms that I want you to be familiar with. Number one is chasing the dragon. Chasing the dragon is where an individual puts their heroin in an aluminum ball with holes in it, and then they put it in a device, and then they heat up the aluminum ball, and it vaporizes the heroin. And what you do is you inhale the heroin vapor, or the smoke that comes out. And the reason why they call it chasing the dragon is because, is this an official marker? Great erase. Okay, it's a dry erasable marker. Because I don't want to have to. How odd would it be if I am the reason why we have to replace the board? You light it. Oh, how cute. It comes like a little flame. Isn't that nice? That's a little flame. You heat it, and what you do is the heroin comes out. And when you heat it up, it comes out, and the smoke comes out almost like a dragon's tail. So as you inhale it, it's like they call it chasing the dragon. Again, that's sort of a more, it's a way to essentially get a more rapid hit. A speedball is heroin plus cocaine. If somebody ingests or injects or inhales heroin plus cocaine, you've got a significant depressant and you've got a significant stimulant on board. Some people will abuse that route of administration. Another thing that, the next thing is a moon rock. A moon rock or also a speedball rock. Moon rock or speedball rock, that is when you combine heroin and crack. And we'll talk about crack cocaine when we, possibly by the end of this lecture. So anytime you have a speedball rock or a moon rock, that's when you're combining heroin and crack. Both fairly intense effects. Body packers are individuals that ingest condoms or other devices that are filled with heroin. They transport it in their gut. The problem is if one of those bags breaks, it's a medical emergency. We were involved, when I was in training, we were involved in a couple of those. For example, folks coming into Kennedy Airport. Kennedy Airport actually has a mini hospital on site for emergencies and also for these types of situations. If I had my druthers, I would rather be dealing with a heroin body packer rather than a cocaine body packer, because a heroin body packer, you can identify it fairly quickly based on the symptoms, and you just give them a lot of Narcan, and that will reverse them. If you have somebody that's ingested pharmaceutical grade cocaine and that breaks, then you're dealing with arrhythmias, you're dealing with seizures, you're dealing with a lot of neurologic issues, and the care, there's no antidote for that. Okay, for the heroin, there's the Narcan antidote that we've been talking about. Okay, what is the clinical picture? Well, the clinical picture is coma and sleepiness, pinpoint pupils except Demerol. What does Demerol do? Dilates. Constipation because it decreases GI motility. For some bizarre reason, these individuals love sweets. I don't know why, but they just want sweets, candy, chocolate, whatever. It's just part of the overdose. Respiratory depression does that. Hypotension because of vasodilation, but also hypotension because you may get anaphylaxis due to what you inject. Again, remember, some of these people could be injecting fibers, they could be injecting particulate matter, dog manure, that kind of stuff. So that might cause an anaphylactic reaction. Hypothermia, if somebody is immobilized for a long period of time. For example, this kind of weather, people that shoot up in a shooting gallery or outside or in some unprotected space, this weather is cold enough to cause hypothermia. So if they're just laying there. Now, also you may see hypothermia secondary to vasodilation. So again, vasodilation can cause hypotension. It can also cause hypothermia. And you can also see crush injuries. So if somebody is hypothermic and they're laying down for a long period of time on a hard surface, like a floor, like a cement floor, if they are immobilized, you will actually get injuries to where they are coming into contact with the floor or the ground. Because again, you don't move, and all of a sudden you're just getting a lot of pressure, like on your shoulders, on your back, on your side, and that could lead to crush injuries. All right, some infectious complications. Endocarditis is one of the key findings. The way the doctor will, or you, because you are going to be able to do a cardiac evaluation, you will hear murmurs. Endocarditis, one of the signs. The signs are murmurs. Now, how many of you have heart murmurs as young adults now? Okay. So, now obviously people, just because you have a murmur doesn't mean you're an IV drug abuser, but if somebody comes in and clearly they have been doing heroin, the physician will listen for murmurs. If he or she hears murmurs, they may evaluate them for bacterial or fungal endocarditis. That is an infectious complications. All of these other ones, AIDS, hepatitis, tetanus, meningitis, those are all related to IV use, IV drug abuse. Those B, C, D, and E. Yeah?
So endocarditis is not related to IV drug abuse?
No, yes. Endocarditis is definitely related to IV drug abuse. So I just did that last group. All of these are infectious complications. Endocarditis and all of these are all related to IV drug abuse. The endocarditis, the diagnostic tool will be if you hear murmurs. That means that there is some sort of infection or fungal particles on the valve leaflets. Okay. Crush injuries, we talked about that. Immobility will be a problem. The patient can also fall. That can lead to crush injuries. And one of the things you'll see is something called rhabdomyolysis. What is rhabdomyolysis? A breakdown of muscle. Okay? So again, the crush injury can cause rhabdo. Now, a positive necklace. This is if an individual is smoking cigarettes and then goes on the nod. So for example, if somebody has a cigarette in their mouth and they start to nod off, what they'll do is they'll burn themselves, and then that'll wake them up. And then they'll move a little bit, and then they'll wake up again. So some of these individuals are also smokers. So if you see burns around the neck, some of my colleagues would call it a positive necklace sign. That means that they have burned their, and that's a clue that this individual, A, is a smoker, but also that they have either smoked that or marijuana or something, but whatever they're doing is they fall asleep and it burns them. Milk is a street antidote. As we mentioned, some individuals do have Narcan available. I remember some of the more affluent individuals would have Narcan available at their heroin parties. Now Narcan is available, but some individuals, and I'll get to your question, some individuals will come in and it will look like they have milk that they have injected. Milk is a street antidote, and what that tells you is that the person has overdosed and their friends have injected them with milk, thinking that milk is the antidote. So clinically, that tells you that the patient you are seeing has OD'd, and their friends have tried to rescue them. So you're dealing with a more significant kind of overdose. Yes, ma'am?
We've been learning about what it's like to find a heroin overdose, but what does somebody who's on heroin look like when they're not overdosing?
That's a good point. Somebody who is not overdosing on heroin looks pretty, well, in a lot of cases they look normal. Because again, people are playing around with heroin. That's a great point. Now, what some individuals will do, like for example, they won't inject, like you won't see track marks, because they'll inject in between their toes. Do I have that on my handout, the various injection points? No. I'll bring you up as an example. Like for example, people will inject in between their fingers. Okay, that is a fairly aggressive person. People will inject, like what will they look like? If you're at the beach, all of a sudden, you'll see track marks or signs of injection behind the knee. You've got some really nice vessels. And that's all you'll see. But like, you won't see them walking around like this. They will appear, if they don't have the drug on board, and if they just recreationally use heroin, you will not be able to distinguish them from others. But you will detect some clues as they go further and further down the path. They might not be, all of a sudden they're into, why are you eating so many sweets? Why are you into that? Remember I mentioned the methadone yawn? You know, like, again, if they are sleeping and they've overdosed, but they're sleeping, and it might be a roommate or something like that, I mean, that's something that you need to be aware of. So again, otherwise normal people who are not chemically dependent, when they are not high, they look pretty normal.
When they are on high, can you be like at a dinner table with somebody and actually realize, or is it more like?
Oh, in a second.
Yeah.
Yeah. If somebody is high on heroin, you can identify it pretty easily. I mean, they will be very lethargic, the pinpoint pupils, you know, the whole deal. There's also something called a pocket shot. A pocket shot, if somebody injects it, can I borrow you for a second? No. Okay, please turn around. Thank you. Now, what I want you to do now, we're in a safe space, okay? This is, okay, now look over there. You see the well-developed, well-nourished young man. Excellent, excellent. Now you see this triangle right here? See, right here? If I inject right in here, I will hit his internal jugular. If I'm really good, I'll hit the carotid. And that goes right to the brain. So if you see somebody that's got extensive bruising, you are dealing with somebody who is hardcore. Because clearly you're injecting there deliberately to find an artery that'll take it right to the brain. Thank you. Excellent, excellent, excellent. Now I'm putting my hoodie up, leave me alone. That's it. So again, those are hardcore, but when I would evaluate a patient, if it looked like somebody who was not a typical drug user, the first thing I would do is I would go and look at the toes. And the minute you touch the sheets, if somebody pulls back, you know that they're injecting in between their toes. So people do try to disguise how they're doing it. Okay. Now, some individuals will come in and they will have ice in the groin or ice in their pants. Ice is also a street antidote. And actually that makes more sense than milk. Because what the ice will do is it will provide a certain level of stimulus to try to wake the patient up. The problem with that is that you, at that point, need to rule out seizure disorder. Because sometimes individuals who have seizures, they will not be able to, they will become incontinent. So you need to see, is this urine, is this water, is this whatever? And again, sometimes you actually see like bits of ice. That means that the individual, again, has overdosed to the point where their friends are trying to wake them up. All right, let's talk about treatment. ABCs are standard: airway, breathing, and circulation. Heroin levels are not useful. Chemistries are standard chemistries. You want to evaluate the blood gases. You want to evaluate the oxygenation status. Because remember, if somebody has become, if their respirations are low, what do you think is going to happen to their oxygen level? It'll go down. And that'll give you, an indication. You don't use physostigmine. The reason why I bring up physostigmine is that some individuals will try to give physostigmine. That is a problem. That is an antidote for anticholinergic toxicity. And if you make a mistake, you can actually cause pulmonary edema. The designer problems. Designer drugs are a big problem. And I'm going to give you some relative numbers that you should be familiar with. Fentanyl, and the reason why the designer drugs are problems is because they're very potent and they can cause instantaneous respiratory arrest. That's the problem. Fentanyl is 100 times more potent than morphine. And this drug, fentanyl, is used pre-surgery. It is an analgesic. Alpha-methylfentanyl, this is the one that's more potent. This is China White. This is the China White designer drug. It's also called Tango and Cash. It's got different names. This is 200 times as potent as morphine. Fluorofentanyl, 7,000 times. And sufentanil, or sufentanil, that's 500 times as potent as morphine. So again, you're dealing with drugs that are thousands of times more potent. Now, heroin is 2 to 4 times as potent as morphine. Heroin is 2 to 4 times as potent as morphine. So when you're dealing with these designer drugs, you really are dealing with very super potent. And these are things that are put out there for individuals who really want to try a significant opioid high. But again, they're also very potent, and what usually happens is when some of this stuff hits the street, the police will go out and they will warn potential users of the risk. Because one of the things that you are concerned about is that your body count will be very high, because these drugs are very, very potent. So let me adjust this. Okay. These drugs will require large quantities of naloxone, and we'll talk about it when we talk about naloxone. When you give naloxone, you monitor the pupils. If the pupils are pinpointed and they open up a little bit, that is a positive response. Now, if it is a standard heroin overdose, you give naloxone, the patient will wake up. If the pupils open up just a little bit, that is a positive response, and it means you may be dealing with a designer drug or methadone or some of the more potent agents. But that means you just continue. You continue with the naloxone. Now, the protocol, I think, we talked about this in our first lecture, right? Like the protocol is you give 2 milligrams, 2 milligrams, and 2 milligrams, 2, and 2. In a busy emergency department, you will give 10 milligrams, 10 milligrams, 10 milligrams. I mean, again, you're supposed to start with 2, but if it looks like you get a little bit of a response, then you might give more. Level of consciousness is, believe it or not, the least important thing. What you monitor for primarily is the respirations. Because if somebody is sort of lethargic, that's probably not going to kill them. What's going to hurt them is if they stop breathing. So that's what you monitor. I mean, obviously you monitor the pupils because that's a really good indicator. But what you want to do is you want to make sure that the respirations are stable. Level of consciousness, again, off the record, although I'm being videotaped and monitored. What you don't want to do is if somebody becomes very agitated, what the nurses will do or what you will do is you will slow down the naloxone drip so that the patient is comfortable but not agitated. And the other thing you don't want to do is you don't want to put them into withdrawal. So again, you titrate, and again, not to be disrespectful, but a nurse says, I'm going to titrate it to the noise level. The patient is very belligerent and very agitated. You slow down the antidote, and the patient becomes more quiet, but they are still breathing effectively, because that is the main thing that you are concerned about. As I mentioned, you give multiple doses. You follow it intravenously, because if antidote will only last for about an hour, so you may need to put the patient on an intravenous dose. The following drugs are going to require more. The designer drugs, propoxyphene, codeine, Talwin, and methadone. So propoxyphene, the designer drugs, codeine, Talwin, and methadone are going to require more. The route that you use in an emergency situation is IV. In the field, they will use the intranasal naloxone administration for the initial component of the rescue. And that's what pharmacies can give out. Yeah.
And were those 4 drugs you mentioned for propoxyphene, methadone?
Propoxyphene, methadone, Talwin, codeine, and the designer drugs.
How do you spell that, Talwin?
Talwin is Talwin. We used to give it endotracheally. Like, for example, if you can, some of these individuals come in and you really cannot find a vein. The patient in that case would be intubated, and you throw a couple of cc's down the endotracheal tube. You bag the patient really quickly, and what that does is it pushes the Narcan into the lungs. And it does get absorbed through the lungs. And at that point, they might wake up and will say, okay, do an IV, and they know the drill. You give them the IV, and they'll find a vein that works. That is against policy, but you know sometimes the track marks are so bad that you cannot find the vein. So they help you find a vein. You wake them up. You can only give 1 dose endotracheally. You can't start pouring Narcan into the lungs because that will cause pulmonary edema. Nalmefene is sort of naloxone turbocharged. It is long-acting. It lasts for 4 to 8 hours. And you're saying, Barone, that's great. The problem is that if they go into withdrawal, you're kind of stuck. See, if you give somebody naloxone, you can actually precipitate withdrawal. And it's very uncomfortable. It's not going to kill them, but it's just a very uncomfortable feeling. So if I give one of you if I give the patient a dose of naloxone and they go into withdrawal, anxious, like, oh my God, what you do? What do I do? If I do nothing, how long will it take for that to go away? No, not 48 hours. No. If I give a dose of naloxone, and I give 1 dose, they go into withdrawal. What do? I don't give them any more naloxone. I wait for them to come down on their own. If I give nalmefene, it's on board, it's an antidote, then I'm stuck for 4 to 8 hours. And what some physicians will try to do is say, okay, why don't we give an opioid? Like actually somebody said, well, can't we give them some morphine to bring them down? That is a mistake. What you do is you provide supportive care, but if you try to chase somebody who goes into withdrawal by giving them morphine, you're in trouble because the naloxone or the nalmefene will wear off. You might have methadone on board. There clearly was another opioid, and all of a sudden you made it a lot more complicated. So basically, the reason why nalmefene is good is because it lasts a long time. The reason why nalmefene is bad is because it lasts a long time in precipitating withdrawal. Okay? Yeah.
Can you use naloxone on Demerol, even though it has the opposite effect?
Oh no, definitely. That's a good point. If somebody has dilated pupils because of Demerol, that is the ocular finding. So what you do then is you still give the naloxone, and then you have to look for other things. The pupils are not going to get bigger, but you look for the respiratory response, and then you just put them on an IV. Okay. All right, let's talk now about withdrawal. Now, To go through this, what I want to do is just explain. I've added some bullet points here. I don't want you guys. Heroin withdrawal requires a lot of different things, but I want you guys to understand how it's managed, because one of the things that we found was that individuals will come into an emergency department and tell you that they're going into withdrawal just so that you will give them methadone, because methadone is addicting. Now, people are going to crave drugs, they're going to be anxious, they're going to be yawning and running, lacrimation. They're going to be like sneezy, and they're going to feel like crap. Later, they're going to be restless, nauseous. So again, it's like first they have the craving, and then it winds up that they are really anxious because they're going into withdrawal. This will not kill you. This will not kill you. It is uncomfortable. It is very difficult. It contributes to the drug-seeking behavior because these people feel so anxious and they just feel so restless, then they need to take more drugs. But if you are in an environment where you do not have access to any, not that this is going to happen in a community setting. Well, it will happen in a community setting perhaps. But in a hospital setting in the middle of the night, that's why they're kind of tough and don't just give methadone to the individual. Treatment. Other opioids, questionable. Questionable. I know it says morphine or propoxetine will codeine. This is one of the things that some individuals might try. Methadone is part of the treatment protocol, but some folks might try that. That is questionable use. As a matter of fact, I would advise against using other opioids other than methadone. Some places, some treatment clinics will actually give large doses of naloxone to clean off the receptors. And some individuals will actually put you under general anesthesia. Put you under general anesthesia so that you do not feel, you do not have the problems associated with withdrawal. But, and then give the naloxone, because the purpose of that treatment is to scrub your receptors. Get all of the opioids off of your receptors. Again, it is controversial because it does involve general anesthesia. This is not something you would do in an emergency department, or this is part of like a rehab, kind of clinic. Methadone is used. Again, as I said, it is a narcotic. It abolishes the cravings and it doesn't cause euphoria. So it's used as a treatment because you remove the euphoria and that will help with the rehab. It is addicting and it can cause overdoses. So with a methadone overdose, you need a lot of naloxone. The opioid suppressant effect lasts for 24 hours. Now, I was going to give you doses, but I really don't want to clutter your thinking. So I'm actually not going to ask you what is the dose. But I'll tell you, but I'm not going to test you on it. You start at an institution 15 to 20 milligrams a day just to help with potential withdrawal, and then it goes up. But what we used to do is we used to give them a little bit of methadone, and then we would put them in a treatment program where they would be handed off to the treatment unit, because you don't manage rehab in an emergency department. Okay. Naltrexone is interesting. It is long-acting. It is non-addicting. It can prevent euphoria, but it does not abolish cravings. It is not an opioid agonist at all. It's a derivative of oxymorphone. So the things you need to know about naltrexone is that it is long-acting, non-addicting, prevents euphoria, but it doesn't abolish cravings. Naltrexone is also one of the drugs that is used. LAM is interesting, LAAM. It is a long-acting derivative of methadone. Here the symptom suppression is 72 hours. So methadone is 24 hours, this is 72 hours. Now, Subutex buprenorphine or buprenorphine is an alternative to methadone. It's a Schedule III. I didn't mention anything about mu receptors, so I'm not going to ask you about that. But it is an alternative to methadone. There is a derivative called Suboxone, which is Subutex plus naloxone. So buprenorphine on its own is an alternative. To prevent abuse, there is a product that combines buprenorphine and naloxone. It is called Suboxone. Get it? Buprenorphine is Subutex. Naloxone, Suboxone. It actually comes as a sublingual film. And again, that's to prevent, and I think we have the question, does naloxone get absorbed orally? The issue is no. So it's a attempt to add a antidote to buprenorphine, which is an alternative to methadone. Yes?
I'm confused about methadone. So did you say we don't use it for withdrawal, but we use it for treatment?
No, methadone, the question is, do you use it for withdrawal or treatment? And again, I just want to clarify. When you put somebody in you do use methadone for withdrawal, because if you give methadone, that will get rid of the withdrawal, but the methadone becomes part of the long-term rehabilitation program. So the answer is that it is used for both. Because if somebody's going into withdrawal, if you give them methadone, that will manage the withdrawal. But once you give methadone, you actually are recommending that somebody go on a methadone maintenance program. And a lot of these methadone programs have pharmacists and physicians involved. So is that clear?
So we don't use other things like morphine or anything like that for withdrawal?
Well, the question about withdrawal, I would recommend not using morphine because, again, morphine is sort of a hardcore opioid. If you give the morphine to treat the withdrawal, they're still going to go into withdrawal when the morphine wears off. The methadone lasts a day. So essentially, you're kind of covering the patient for a day, and then you put them on a methadone maintenance program. But you wouldn't do that in the acute. You wouldn't put them on methadone maintenance in an emergency department. Okay, yes?
With methadone and Suboxone and everything, are they on it for the rest of their life, or should they get titrated off eventually?
The question is on methadone and on Suboxone, are they on it for life? The answer is possibly, because these drugs are used as part of long-term sort of recovery or long-term rehabilitation. One of the items that came up the other night, which was very valid, is that some of these drugs, like for example, getting somebody off of Subutex is difficult because these are drugs that will affect the same receptors. So they may need to be on them long term and eventually get weaned off of that if they really want to go clean. But some individuals need to be on the drugs for a long time to stay on recovery. But again, stopping those, you're going to precipitate withdrawal as well. And you can also overdose. The sympatholytics, clonidine and propranolol, those are used to relieve the agitation, relieve the anxiety, basically calm down the cardiovascular response. And they will try other agents like benzodiazepines and chlorohydrate to basically calm the individual down. Now, there is a lot of work that's being done in terms of dealing with the opioid epidemic. I just want to draw your attention. This is really self-explanatory, but there is a recommendation about naloxone from the Surgeon General. I'm not going to test you on it, but if you want, you should take a look at it and just familiarize yourself as pharmacists. Basically, they really are advocating widespread use of the antidote. It's just a two-pager. Some of the things, you have to approach addiction and overdose with science and compassion. Naloxone is very good, but it's only part of the issue. Waking somebody up from an overdose is not really long-term treatment. This is just an acute emergency, so you have to refer them to addiction treatment, and you have to try to figure out a way to prevent the addiction. These are some of the things, the major priorities: treatment and recovery, promoting the use of drugs like naloxone, better numbers about the epidemic, providing support for research, and also advancing better practices in pain management. Just as an aside, one of the things that we're hearing is obviously that our governor wants to legalize marijuana. And again, I'm not going to get into that. I mean, as pharmacists, a lot of pharmacists are just against that. But one of the things that came out of the conference the other night was that some individuals may start experimenting with non-opioids like marijuana, and then actually they might want to try other stuff. So that is one concern that some individuals have. Although other studies have shown that in places where the marijuana is available legally, the opioid use goes down. So I think we had this, people will try stuff. So I'm not weighing in, but you do need to familiarize yourself with, what are some of the epidemiologic issues, just as pharmacists. Just by a show of hands, how many of you would be in favor of, and again, I'm not judging, how many of you would be in favor of legalizing marijuana in the state of New Jersey? Hands high? Okay. How many of you are against it? So, and the rest of you just don't care?
On the fence.
You're on the fence. Okay, all right. Well, a lot of people are on the fence. What I saw was most people are in favor, some are opposed, and some are on the fence. But you will be asked about that around the holiday table for sure. Okay. Let's talk about patient 49. Let's talk about patient 49. Now, if you take a look at the picture, this clearly... It's not opening? The internet's broken? Somebody break the internet?
The internet did too much opioids, he's in depression now.
The internet is stoned. Is it coming up? Can you see the track marks on it? Yeah, can you open it? Yeah. Okay, so if you take a look at the picture, notice it looks like she's got those small bruises. Those are track marks. They're small bruises, they're track marks. In some places, in some situations, you can actually see that the skin is depressed, almost like a little pothole, because the subcutaneous inflammation and the abscess actually causes the architecture of the skin to kind of collapse. Now this looks pretty good, but obviously looking at all that, would you say she is a fairly frequent user or not? See that? Not yet? Sorry. Those of you who have it, is she? Well, there's a lot of track marks here. So again, a 22-year-old woman was found somnolent. That means sleepy, shallow respirations. That's hypoventilation in a public restroom with a syringe in her arm. Now, if you can't figure out that this is some sort of an overdose, you are not an Ernest Mario School of Pharmacy student that has taken this class. Okay? Like, you don't even need a syringe in the arm. But what would that tell me, though, is, in all seriousness, if somebody is found with a syringe in their arm, that means that they probably have taken more than they are used to. Because these individuals are very savvy in calculating, how much they need to get high. So the fact, they sort of said basically, okay, you knucklehead, let's give naloxone, and then the patient became more alert on the way to the hospital, and case closed. Respirations 8 a minute. Is that normal? No. So she's clearly hypoventilating. Her pressure 110/70. That was normal. Her pupils were pinpoint. Again, I circle that. That's pretty straightforward. She had shallow respirations, and she had track marks to bilateral upper extremities. So on both of her arms, she had track marks. And again, she had sinus bradycardia, which means that her heart rate was slow. They tested her urine for opioids, and it was positive for opioids. This is a very easy case. So what findings suggest that this is somebody that's going to respond to naloxone? Well, somnolence, respiratory depression, and small pupils. Perfect K question. Now, if this said somnolence, respiratory depression, and dilated pupils, what would you think? Demerol, okay? But again, you still get the somnolence and the respiratory depression. So what do they say? Well, naloxone is an antagonist that will reverse the depression and lethargy, okay. History and physical exam are sufficient, okay. Laboratory testing is typically unremarkable. Okay. Did they get heroin blood levels? Are they useful? No. But you got positive heroin, you got positive opioids in the urine. Patients who respond to naloxone should be observed for 3 to 4 hours. That's good, right? And naloxone may precipitate withdrawal. We already talked about that. And the present patient got a second dose of naloxone because she got more tired and her respirations got slower. So how could they have avoided that? Start an IV. You start an IV, and then you just monitor based on the IV, because the naloxone is only going to last about an hour. Again, now if this lady would have gotten into withdrawal for whatever reason, and it's gotten really agitated, within an hour, all of a sudden she starts to calm down. But you need to monitor the patient. You can't just leave her alone, in bed 6 and then walk away, because she could stop breathing. All right, so clinical pearls. So we agree. Other than I would have started an IV, this is fine. Opioid toxidrome, lethargy, respiratory depression, and meiosis, which is pinpoint pupils. Opioid-like drugs may mimic the opioid toxidrome. I doubt that a clonidine overdose looks like this, so, bag that. Number 3, small doses should be used in adults to avoid precipitating withdrawal. That's okay, but I've seen withdrawal with just a little bit of naloxone. If you give 10 milligrams of naloxone, the odds are, you have a greater chance of precipitating withdrawal. And as the duration of naloxone is shorter than many opioids, it is prudent to observe the patient, which makes sense. So again, we agree with everything that they are talking about. Okay, good. Let's do some more drugs of abuse. Is that okay? Are you ready? Are you ready to get a little bit cocaine? Now again, what I'm going to do with cocaine and the rest of the stuff, I just want you guys to understand what are the major symptoms, and I will tell you what the tricks are in terms of how to identify these overdoses. Now, first of all, I want to talk about cocaine. Cocaine is also called the Coke, Snow, Blow, and Nose Candy. Interesting, huh? Coke, Snow, Blow, and Nose Candy. So if somebody says, oh, they've just been doing some blow, that means that they have been ingesting cocaine. The largest users are your age range. As a medicinal agent, it is used for plastic surgery around the eye. It is a good local anesthetic. So plastic surgeons use it around the eye. And the reason why they do that is because it is also a vasoconstrictor. It is a vasoconstrictor. So around the eye, what it'll do is it will stop the bleeding. Remember vasoconstrictor, because that will feature later. Now, the main difference between cocaine hydrochloride and crack, the two main differences. Number one, cocaine hydrochloride is the older formulation and it is easy to cut. That means you can add a lot of adulterants to it to increase the value if you are the dealer. The problem with that is that people will put all sorts of crap in there, and somebody thinks they're doing cocaine and they're not. They're doing a little bit of cocaine, but there's other stuff in there, and we'll get into why some of those complicate the picture. This is inhaled, snorted, IV, and oral. You cannot smoke cocaine hydrochloride because it degrades. So if somebody tells you, she's been smoking coke, what she's doing is she is smoking crack. And that tells me that her high is much more intense and her depression is going to be much worse. The interesting thing is that you have limited absorption via vasoconstriction. So, for example, if somebody snorts cocaine, if they snort the cocaine, their blood levels will go up slowly, because with the vasoconstriction, it will decrease the blood flow and it will slow down the absorption. If somebody injects cocaine, the blood level will go up very rapidly and it will decay. If somebody smokes crack, very, very intense high and very, very quick downward phase. So basically, smoking crack gives you the same effect as IV. Again, a very, very strong euphoria, just based on the fact that you get a vasoconstriction. The vasoconstriction also causes nasal damage. I've seen patients that after years or months of snorting, they will actually deteriorate their septum. They will deteriorate their septum. And sometimes you'll see irritation around the nose. And when you do a nasal evaluation, you will see perforation, that the septum is just destroyed because of the fact that you have caused enough vasoconstriction to cause a breakdown in the cartilage. I mean, this is serious use. This is serious use. A line is, 10 to 35 milligrams. The adulterants, the average is about 50%, and people will use sugars, stimulants, local anesthetics, talc. Again, talc is inert. Individuals will also add benzocaine, lidocaine, and tetracaine. They will add benzocaine, lidocaine, and tetracaine. benzocaine, lidocaine, and petrocaine. That's because if you've seen in the movies somebody, taste the cocaine, and it's like, okay, get the trucks, this is good cocaine. Well, I mean, that's not a real analysis. I mean, let's try it. Yeah, but the cocaine it's an anesthetic, so how will your tongue feel? Numb. Well, if you take Novocaine or lidocaine, how is your tongue going to feel? Numb. Okay, so you use an adulterant that gives you the same numbing effect, for the individual. Some individuals will add hallucinogens and PCP, the actives in marijuana, so hallucinogens, PCP, and marijuana, we'll talk about that. That increases the quality. It increases your profit. We already mentioned hydrochloride can be snorted, injected IV, applied to various types of mucous membranes, and it causes a generalized sympathetic activity. What this drug does, one of the reasons why people like cocaine, is because it gives them a sense of euphoria, but it also gives them a big sympathetic rush. Now, in some South and Central American areas, local farmers who are out in the fields working at high altitudes, they will take the coca plant and they will chew it. And that will cause enough of the alkaloid to be sort of released that it will keep them energized and it will keep them moving. Totally legitimate. This is how they do it to work all day and to stay strong and to do that. Cocaine also gives you the ability to perform complex mathematical problems very quickly. I'm not advocating it, but not for pharmaceutical calculations, but it does have an effect of making you sharper. That's why some individuals who are in the financial world might try this drug as a reward mechanism, and also because it does improve your stamina and your functioning. Again, I'm not advocating it for that. This is just, when you look at the cases, this is what they said. Yes?
Like 100-something years ago, let's say they had cocaine and Coca-Cola, that they had in there as this kind of stimulant. You stole my joke, but yeah, in the old days, Coca-Cola really had cocaine in it, and back then, things really did go better with Coke. Wait for it. I'm sorry, look, I got a jokester and like Miss Serious over there. Okay, it's true, things really did, no, but Coca-Cola it did contain cocaine. Now it contains what? Caffeine. Okay. Which is not cocaine. Anyways, okay, I'm not going to fall into your diabolical trap, young Jedi. Let's talk about crack. Now, crack is about $10 to $20 a hit. So crack is cheap. Crack is cheap, and it's fairly effective. It's almost pure cocaine. It is the freebase. The reason why they call it crack is different schools of thought. It makes a crackling sound when it is smoked in a crack pipe, or it looks like little rocks. It is a frequently overdosed drug because it is so potent. It has a high number of users because it is very addicting. That is the formula for those of you who are interested. It melts at 98 degrees. It vaporizes, so you can freebase it or you can smoke it in a pipe. Some individuals will actually mix this with cigarettes, which is really quite interesting. Putting it in with a cigarette. We'll talk about that. Some individuals will have like custom-made cigarettes, and then they'll just have a little bit of crack in the cigarette. So you're smoking a cigarette. As you smoke the cigarette, the crack sort of volatilizes and you'll get high that way. Smoking gives the same feeling as IV. This is an important point. This is why it's so addicting, because when you smoke crack, it's like taking IV cocaine, which, based on the whole addiction model, you feel really high really fast. It's fairly potent, so it's cheap, it's potent, you have repetitive behavior to stay high. It has a very intense psychological effect. So this effect here, when you feel really high and strong, that is called euphoria. And then when you go down, that is called dysphoria. So euphoria is on the way up, dysphoria is on the way down. I have been told that the down slope, the dysphoria, is worse relatively than the euphoria. And what that does is it encourages you to take more. Because you feel so, it's not like you're up 100% and then you're down 50%. No, you're up 100% and you're down 125%. You feel so crappy, you have to take more to get back up. And after a couple of doses, you are dealing with a chemical dependency issue. One item here is that people will combine this with ethanol, marijuana, opiates, and other central nervous system depressants to decrease the irritability. So here you're dealing with very potent CNS depressants to try to decrease the irritability of a very potent central nervous system stimulant. So here you're dealing with some fairly aggressive drug use. Now, what are some of the effects? I apologize for this mic. It really annoys me. Okay. Good in the back? Okay. All right, what are the effects? Now again, what I want you to think about is super stimulant. So, central nervous system stimulation, you might get seizures. Cardiovascular, sinus tachycardia, VT is ventricular tachycardia, hypertension, cerebral hemorrhage. Again, you don't have to memorize these things individually because you will know them. Okay, this is a full-on stimulant. Increased heart rate. Of course it will increase your heart rate. Now here it says it's due to the blood pressure and how quickly it's due to the blood level and how quickly the blood level changes. I'm not going to bore you with all of the details, but there's a school of thought that says, like for example, I'm not going to test you on this, but if you really do multiple doses of this, saying that here you take some more, and then here you just keep snorting, and ultimately you're up here, the blood level is the same, right? Isn't the CP the same? The feeling is that this is worse. Because you get to the same level, but here you get there over hours. Here you get there over minutes. That's the intensity. That's from a pharmacokinetic, pharmacodynamic. That's why it's like it's that much worse. Whenever you get young kids coming into the emergency department because they have chest pain, that probably is due to the fact they may be having an infarct or angina. Usually teenagers and 20-somethings do not get chest pain. This drug causes vasoconstriction. It constricts everything. It constricts the coronary arteries. So again, that is a clue. If you get a teenager coming in with chest pain, and they're, clearly not in the right age group for a heart attack, their EKG will show heart attack. Their EKG will show ST segment changes because you're vasoconstricting. You're vasoconstricting. Okay, you've got ischemia. You've got paranoid psychosis, migraines, a lot of stuff. Now here, paranoid psychosis, this is a control psychosis. People come in and they are psychotic and they will try to control you. It's a controlled psychosis. One of the other drugs causes a fear psychosis. A fear psychosis. The individual will say, look, get these other people out of here or else I'm going to kill you. And you look around and you're like, there's nobody there. So I'm having a hallucination, I'm having a psychotic event, but I am trying to control the event. A fear psychosis is, why are there so many people here? I'm really scared. Can you get rid of these people? You see the difference? I am dealing with a hallucination on both counts. One is a control psychosis. And that's why people that are on a cocaine high, they feel that they are masters of their universe. Okay? Because again, they feel smart, they feel stronger, and they feel they can control the environment. If somebody comes in and they're also depressed, I mean, if they have any kind of depression, I give them naloxone. Just give them naloxone because, again, you give them naloxone if they are depressed. False sense of confidence or euphoria, we talked about that. Pneumonia because of inhalation. Okay? Now here the pupils are dilated and reactive. The pupils are dilated and reactive. If you have an anticholinergic on board as well, or maybe that is what is causing the psychosis, the pupils will be dilated and what? Unreactive. The pupils will be dilated and unreactive. Yes?
I had a question about the fear psychosis.
Yeah.
Is that something that people on this drug will be experiencing, or is that just a different type of psychosis?
No, the question is, will people... not everybody will have a fear psychosis. Not everybody will get psychotic. But if they come in and they're starting to have hallucinations and they are psychotic, when you talk to them, a lot of times it is psychosis, but they will threaten you. They will say, get rid of these animals, get rid of these people. So again, you can tell that, but not everybody will do that. I mean, how many of you have seen somebody that's tried cocaine? Okay, how do they act?
Very hyper, assertive.
Okay, so hyper and assertive. What else? Yes?
Doesn't it depend on what they do with it too, because they react differently as well?
That's a good point. It depends on what they take with it, but let's say they just did, so the answer is yes, it does. But what if it's just cocaine? Yes?
Aggressive?
What?
Aggressive.
Right, they may be aggressive, but you guys are dealing with individuals who maybe have done a little bit. I mean, some people, after a little bit of cocaine, what are they like? They're pains in the ass. They'll be talkative. They won't shut up, right? They'll just jabber, like they hear a noise. What's that? You know, I mean, and again, to your point, sometimes they'll get more. So again, it's the continuum. Sometimes they may just be a little jittery, depending on the dose, and also depending on their underlying personality. So they'll just be a little jittery. And you kind of say, well, why are you so jittery? You know, and you can kind of determine that something, I'm not looking at this row in an accusatory way. You know, so they just get a little bit anxious. Sometimes people get a little paranoid, like they'll hear a noise, or they'll think it's the police or something like that, or they'll think, and then as it gets worse and worse, they may have these psychotic events. But euphoria, some people love it. It makes them feel great, and it makes them feel very powerful. Hyperthermia, because they're, yes ma'am?
What does VEA stand for?
VEA is ventricular ectopic activity. Those are extra heartbeats. So basically just know arrhythmias, because again, if you have a lot of stimulants on the heart, it can cause arrhythmias. Rhabdomyolysis, they're moving around a lot, and it can actually hurt their muscles. Malnutrition, because they don't care. People who abuse cocaine do not care a lot about eating. We talked about the onset. We talked about the duration. Fatal dose, that's just based on some clinical reports. Death is probably due to anoxia and maybe secondarily to seizures. Because again, if you seize, you might stop breathing. We talked about no precise relationship between blood level and seizures, MI, or death. That's tough to determine. And tolerance is unclear. Tolerance is unclear. Some individuals say that they start with cocaine and then they have to do more and more cocaine to get that desired effect. Some individuals just start with a dose, they have a good supplier, they stick with a certain dose, and they just need it as, they just use it as needed. Now, how do you treat? Mild intoxication, you leave them alone and it's just supportive. If they're really anxious, you give them benzodiazepines. If they're seizing, you give them benzos. The doses are there. Plus phenobarbital, phenytoin. Now, this is one type of seizure where you would treat. So cocaine seizures you do treat. What seizures don't you treat? Alcohol withdrawal. Very good. Status epilepticus. If they're in status epilepticus, you treat them as per a protocol. If they're paranoid, you give them Haldol. Haldol is a very good drug anytime you're dealing with an overdose that is hallucinating, that is paranoid, that is dangerous to you, dangerous to themselves. Give them Haldol or haloperidol, and that calms them down. One of you mentioned, what about if they combine it with other drugs? Beware of the speedball, cocaine and heroin. If somebody injects cocaine and heroin, they could come in one of three ways. From a CNS point of view, what are those three ways? They can be depressed, they can be elevated, or they can be absolutely normal from a CNS point of view. So it's super plus, super negative, or neutral. And then the party really starts. Because you give them time, and over time, what if the cocaine wears off? And they're on a designer opioid, what's going to happen then? They're going to get more and more depressed. What if the opioid wears off? They're going to become more and more stimulated. Again, that's the interest, that's the clinical piece. And I think I told you guys the story. We had, you often have mixed injections, and they come in and they're in a coma. You give them naloxone, and you erase the narcotic effect, and all of a sudden you have unopposed cocaine toxicity. We're full-blown psychosis. Okay, that's just because you have erased the negative. Okay, at that point, what do? Leave them alone and let them come down on their own. With increased temperature, you use a cooling blanket. Increased temperature, you use a cooling blanket. If your hospital has money, it is basically a refrigerated blanket. In places where I've been, you get a sheet with cold water in the sink, you wring it out, and you put it on the patient to cool them off. If you really have some dough, you put a fan. That's high tech at University of Illinois, or Bellevue, or Queens General.
When was it? The Ice Age?
Is he saying I'm old? No, it is current, sir. I don't know what hospitals you go to. Maybe they have refrigerated rooms or no, that's what you do. You do what you have, wise ass. I know he didn't mean to say I was like a dinosaur. No, that's what you do. A cooling blanket is just that, just to cool the patient off. Note to self, wise guy. Okay. Don't give, the reason I have caution with thioridazine, some of the antipsychotics may actually precipitate malignant hyperthermia. That's why I like Haldol or haloperidol. It rarely causes a problem and it calms the patient down. In some cases, some of the antipsychotics may cause malignant hyperthermia, which you don't want to use because the patient may be hyperthermic. You can precipitate that. That is a problem, in terms of that. Are we out of time? 10? Okay. All right. Be careful. I'll see you guys Friday. Thank you. Good job today. Good questions, by the way. Good questions. Thank you. That was not a call. I say it's wise ass.
Sorry for that, Thomas.
That's fine. That's a joke. You probably. It's very primitive. No, but they still do that. They still do that. Yeah. Yeah. That's it.